burnout and depression, particularly among psychiatrists, because during the course of the pandemic, we saw a lot of changes. A lot of countries went into lockdown. People were forced into isolation. Their entire lives changed. The average person was pelted with such a huge amount of changes that the common man simply couldn't cope. And over time, the general public began to realize the importance of mental health, and they began to seek help for their issues. And as that happened, the caseload for psychiatrists also increased, and they started facing the same issues that other frontline workers started facing. And as our dean mentioned during his welcome speech, even psychiatrists, even though they're not like frontline workers, they are also dealing with two problems: their own burnout and depression, and also that of their patients. So my study is a literature review because I wanted to gauge the levels of depression and burnout among psychiatrists in different parts of the world. And when in my literature review, I found that there is an astute lack of data in the Caribbean region, and I hope to be able to gather data firsthand in my future studies. So let's define burnout. What exactly is burnout and depression? Now, the term burnout was first actually introduced in 1971 by an American psychologist. So it came from the mental health department. His name was Herbert Freudenberger, and he described burnout as a state of mental and physical exhaustion caused by one's professional life. Later on, Maslach and Jackson defined burnout as a psychological syndrome that occurs in professionals who work with other people in challenging situations, that is characterized by A, emotional exhaustion, B, depersonalization, and C, a diminished sense of personal accomplishment. Now, depression is a clinical diagnosis. It is a mental health disorder characterized by persistently depressed mood or loss of interest in activities, causing significant impairment in daily life. It is generally diagnosed through the DSM-5. Now, I chose burnout and depression as the two entities of my study because research has found that the idea of overlap between burnout and depression, including research conducted among healthcare workers, it actually proposed that burnout is a manifestation of the depressive syndrome. And in contrast to burnout, depression is nosologically well characterized and diagnosable using clinically validated instruments. There are various clinically approved surveys and also DSM-5 criteria for diagnosing depression. And to etiologically connect this depression with work, the investigator can ask the participant whether they will attribute their depressive symptoms to work-related issues. So how does this affect patient care? Now, we've all heard when we go on our flight, we've all heard the air hostess say that in case the oxygen mask drops down from the overhead chamber, we have to put on our own mask before helping the person next to us. The same analogy applies in the healthcare professional, especially in the mental healthcare professional. With mental healthcare professionals, like psychiatrists, psychologists, they must be first aware of their own issues and first be able to deal with their own problems before being properly able to help their patients. Research shows that poor well-being and burnout affect the quality of healthcare that patients receive through reducing the doctor's ability to empathize, to display positive attitudes and listening skills, and by increasing the number of inappropriate referrals made. Burnout and poor well-being can also have negative consequences for patient safety through a variety of mechanisms, including reduced cognitive functioning and decision-making abilities, a lack of headspace, and fatigue. Furthermore, it was suggested that the relationship between well-being and burnout and mistakes is likely to be circular, meaning burnout causes mistakes leads to more burnout, and eventually traps the doctor in a vicious cycle. The relevance of this study. Over the last year, due to maybe the pandemic, we have come to realize the importance of mental health and the importance of being able to seek help from a mental health professional. Now, it is very important that we preserve the quality of the mental health care service provided to our patients. there is considerable evidence that burnout has negative impacts on the physical and mental well-being of an individual worker, thereby affecting the functioning of the team and organization in which they work. And this leads to an overall lower productivity and impaired quality of care provided to the patients. The ultimate aim of any healthcare professional is the well-being of their patient, and anything that affects that must be addressed immediately. Unfortunately, very few studies have been conducted to assess the prevalence of work burnout during the pandemic, globally and locally. Like I mentioned before, there is a lack of data in the Caribbean region. In addition, there is a lack of knowledge about the impact of an infectious disease outbreak on non-frontline health workers, such as psychiatrists. The tackling of mental health of healthcare workers during the pandemic is essential, and this will strengthen the overall quality and capacity of the healthcare system. The role of psychiatrists and other mental health providers as a source of psychological support and reassurance to both the public and other frontline healthcare workers is indispensable and valuable, especially in times like this. Now, in my literature review, I came across a total of 32 articles which were related to my topic, out of which 18 were excluded because they were not specific to psychiatrists or they did not specifically deal with burnout and depression. So I included a total of 14 articles which were specific to psychiatrists and which were specific to burnout and depression. And these 14 articles were fortunately spread across 14 different countries. So it allows us to gain a wider picture. In the 14 articles, there were 4 methods of survey used to assess the levels of burnout and depression among the participants. 2 of them, called the Maslach Burnout Inventory and the Copenhagen Burnout Inventory, were used to assess burnout, while the other 2, the PHQ-9 and the GHQ-12, was used to assess depression. Now, the Maslach Burnout Inventory was developed by Christina Maslach, who actually defined the term burnout, as we saw earlier. And it assesses 3 areas: emotional exhaustion, depersonalization, and diminished sense of personal accomplishment. The Copenhagen Burnout Inventory was recently developed in Denmark, which uses a 19-point survey to assess client-based, work-based, and personal burnout. The Patient's Health Questionnaire and the General Health Questionnaire are screening tools used to assess depression in a primary healthcare setting. Now, let's take a look at the data collected by these 14 articles in various countries, ranging from Saudi Arabia to Thailand. We noticed that Italy, for example, has one of the highest rates of burnout. As we know, this can be attributed to the initial surge of cases, COVID-19 cases in Italy. Russia has also a tremendous amount of burnout, which in the particular study was attributed to the lack of the number of healthcare workers. Iran has a high rate of depression, which is attributed to the stigma associated with mental health issues in the country. On an average, we see that 41.9% of psychiatrists reported being burnt out, and 40.8% of psychiatrists reported experiencing symptoms of depression among those who were surveyed. Like I mentioned before, there is a good amount of data in developed countries, but little information is available from the Caribbean and other less well-developed regions. Now, any topic in mental health is a complex topic, and the same can be said for burnout and depression. It has various causes and it has various associated conditions that can increase or decrease the risk of a person developing symptoms. For example, from the 14 studies, I found that the female gender, younger age, having chronic comorbid conditions, or having children or elderly relatives at home were common risk factors. These, for example, having close relatives who you might expose to COVID-19 would cause anxiety among doctors, leading to burnout. Other factors affecting burnout and depression include living alone, lack of vaccination, lack of personal protective equipment, and inadequate compensation. Other factors particular to the mental health field have been proposed to make workers in this field more vulnerable to burnout. These factors include stigma of the profession, demanding therapeutic relationships, and threat of violence from patients and patient suicide. Psychiatry is a field where it is rare to see a person come to a full resolution, and this has increased during the pandemic when a doctor is unable to lead a person from on the onset of symptoms to full treatment. And this caused a toll on the mental health of the psychiatrists themselves, leading to depression. Now, my observation from the studies was that burnout and depression was mainly caused by two factors, that is workload and work environment. Because of the COVID-19, there was an immense increase in workload among mental health workers. And as a summary estimate, emotional exhaustion being 40%. Work environment, for example, high emotional involvement and high idealistic expectations among mental health workers. There are two sides to this coin. While they allow one to achieve a high level of professional satisfaction, they can also produce high levels of stress and frustration if they lead to an excessive sense of responsibility and impotence towards chronic and invalidating pathologies, like I mentioned before. So what are my recommendations? What can be done to make sure that this does not happen in the future and to fix the issues currently prevailing in the mental health industry? So several studies have highlighted the role of the increased perceived workload and organizational problems in the development of workload. Maslatch and colleagues herself have argued that the main causes of burnout are related more to the working environment than to the personal characteristics. And therefore, preventive steps should be taken to improve the factors related to the working environment. Issues such as heavy workload, changes in duty rosters to accommodate the new needs, and cancellation of vacation, as well as less access to PPE, may have caused unfavorable state, and all these needs to be rectified. Like, for example, interventions may include increasing the awareness of work-related stress and burnout, promoting mindfulness and self-care practices for promoting mental well-being and ensuring optimal mental health services. Digital technologies can be used to address workplace stress and deliver mental health interventions. Organizational policies and practices emphasizing on addressing burnout among healthcare providers must also be improved upon. So these are my references. I'm open for questions now. Thank you.